welcome to this session on screening in epidemiology. Today we are going to look at what is the meaning of the term screening and how it differs from diagnosis. Now we need to understand that symptoms of a disease do appear and are caught by applying diagnostic tests. But we need to also understand that long before symptoms occur, there will be processes going on at the microscopic level whereby changes in the cells are likely to occur. And this can be detected by screening. So let's look at what is the definition of screening. In 1957, the Commission on Chronic Illness has given this definition, which you can see on the screen. The words highlighted in color are quite important when we understand this concept. So screening is basically presumptive identification of unrecognized disease, or it could be a defect, and this identification is possible by application of either tests or performing examinations or procedures, and these should be rapidly be applied in order to sort out apparently well persons who probably have a disease from those who probably do not. Now, the words to remember in this particular definition are: it is either a disease or a defect or a disorder, and screening test, and it is applied to population. So these are the key elements of this definition. Now, how does screening help us in finding out more about a disease? So for example, if we look at 10 students who look to be apparently well, and we need to find out if how many of them are having a high blood sugar, what I can do is I can do immediately a finger prick test. So I'm performing a test and I'm doing it rapidly on apparently well person. So I assume that all the 10 students sitting in front of me are well, and I may find out that few students may have a higher blood sugar level as compared to others. So I would put those who have a relatively high level of blood sugar in the category of those who probably have a disease. Please bear in mind that by getting a screening result which is positive, you cannot make an assumption that that person suffers from a disease. And this is the basic difference between screening and diagnosis. So what screening does is this. If you look at this particular figure, you can see that we start with apparently well population. What I mean here is people who do not show symptoms of the disease. But in that case, it includes all people who are well because they don't have symptoms, plus all those with undiagnosed disease. So there it is a possibility that people who do not show symptoms of a disease necessarily do not actually are free from the disease. So they may be suffering from a disease which has not yet been diagnosed. So this is our apparently well population, which will be screened, right? So we select this population to which we apply our screening test. Now what you can see, the circles in this particular figure, we can see what they all mean. The plain circles are those people from this population who are negative on application of the screening test. So when I apply a screening test, I can get a negative result or a positive result. So negatives are the ones who are presumed to be free of disease under study. The word presumed here has got a lot of significance because we are trying to just assume, or we are trying to just make a prediction that these people may be free from disease. Now if you see the circles with a cross in the center, those are the people who are positive detected on the screening test, but who actually do not suffer from the disease. So they have been tested positive by the screening test, okay, but they do not actually have the disease. Whereas the dark circles, the black circles, are the ones who are positive on screening test and who also have the disease. So if you look at here, we have the negatives and the positives. Positives are the ones who are presumed to have the disease, or they are likely to be at an increased risk of the disease in the future. Now, who are our targets for diagnostic procedures? Those people who turn out to be positive on a screening test are then subjected to diagnostic procedures. So this is quite important to understand that by getting a positive screening test result doesn't make a person diseased. This person who shows a positive screening result has to be further subjected to diagnostic procedures through which we can know whether the disease is actually present or absent. For all those in whom the disease is present, we need therapeutic intervention. So what's important is that just having a screening test in place is not going to help unless and until we have diagnostic procedures as well as sufficient therapeutic interventions with us. So this test which we are talking about must be able to determine the difference between the negatives and the positives. It should be done at an acceptable cost, and there should be no side effects, or at the most least side effects from the procedure. Okay, we need to understand that screening procedures generally are inexpensive and rapid or easy to perform, but we also know that there is a likelihood or a chance that those people who are tested negative on a screening test may have a disease. Similarly, those who are tested positive on the test may be free from the disease under study. So we need to understand this concept that it has to be accepted that there will be some cases which will remain undetected even after a screening test. So when we perform a screening test, we need to realize these features. Next, we move on to a timeline of a disease. When we talk about a disease, before even the symptoms occur, as we have already seen, there are chances that there are changes occurring at the microscopic level, at the cellular level, at the nuclear level. So in this context, onset of a disease, the disease being detectable by a test, signs or symptoms of the disease, and death from disease or other causes can be considered as the timeline or the spectrum of the disease. Now, if we have to take these timelines, the phase from appearance of signs or symptoms until death from the disease or other causes is called as the clinical phase, whereas the phase which starts with the onset of the disease and ends till the disease is detectable by the test is known as the preclinical phase. Now, what is the relevance of understanding timeline of the disease? We need to understand that the disease process has already been initiated before occurrence of signs or symptoms, right? And even before the appearance of signs or symptoms, we should be able to detect this particular disease by applying a screening test. So now, if we have to look at this duration, that is the time interval between the test being detectable, the disease being detectable by the test and appearance of the signs and symptoms, this is known as the detectable preclinical phase of the disease. Now, this phase is very, very important because this is the time when the screening test should actually be performed, and by doing so we hope that the detection will lead to earlier treatment, and earlier the treatment, hopefully better is the outcome. But we need to also remember that there is a lot of controversy about certain tests being applied at different time intervals. For example, if we talk about routine mammography screening, there has been a lot of debate over what is the ideal age or the recommended age at which this screening has to be performed. Now, the recent controversy which is going on is about screening men for prostate cancer by using what we call as PSA, prostate specific antigen. We will look at that in our presentation today later. So, based on this detectable preclinical phase, there is another definition which is known as clinical screening, which is used by clinicians. So, we talk about assessment of preclinical disease. So, we saw in the earlier slide that we have clinical and preclinical phase. So, we are trying to assess preclinical disease in patients by using special tests or examinations so that we can identify those individuals who need special intervention. Now, the word special intervention here means subjecting them to diagnostic procedures. Please do remember, by performing a screening test, we cannot say a person is suffering from a particular disease. This is a point to remember when we talk about screening. So this is important when we look at a screening test. Now the question arises, when can screening be beneficial? For which diseases should we be screening individuals? So the first point to remember here is the disease should be serious enough. So for example, cancers or a disease like hypertension, which itself is a risk factor for other non-communicable diseases. Now this disease is serious in terms of outcomes. Either it causes death or it may result in disability. The second criterion on which we can consider that screening could be beneficial is when the treatment before symptoms if occur is more effective than the treatment if it is delayed until symptoms appear. So for example, when we do cervical screening, our aim is to detect not cervical cancer, but our aim is to detect precancerous lesions on the cervix, which if untreated are likely to cause cancer in the future. So the screening for cervical cancer is mainly for precancerous lesions which predispose the woman for cancer in future if undetected. And the third reason when screening can be beneficial is when the prevalence of the disease in the detectable preclinical phase is relatively high. This is a point which is very significant and important to remember, is prevalence of the disease, but not general prevalence. We are talking of prevalence of the disease when it is being detectable by the test before appearance of signs and symptoms. So these are the three criteria which we can consider when we consider the benefits of screening. Now, when we talk about screening, we talk about validity of the screening test. Now, validity of test is nothing but whether the test is able to accurately distinguish between healthy and diseased individuals. For example, if I want to screen women for cervical cancer, how effectively is the test able to detect between those women who are suffering from cervical cancer as compared to those who are not suffering from cervical cancer? In this context, we have two parameters to consider, and these are sensitivity and specificity. So the probability of correct test in screening, if it is probability that the diseased people test positive, it is considered sensitivity. And if it is the probability that the non-diseased people test negative, it is known as specificity. So now when we look at this, we try to make a 2x2 table. Now this is a 2x2 table. We have seen 2x2 tables earlier when we have seen risk calculations. For sensitivity and specificity calculation for a screening test, what we put along columns is the disease status, and this disease status is a true disease status. And how is it determined? By subjecting those who were positive through a screening test to a diagnostic test, after which the person may be diagnosed as being diseased or not diseased. Whereas along the rows we have the test results for the screening test, whether it is positive or negative. Okay, so this is the difference between the 2x2 table we use for risk calculation. So now, say how to calculate sensitivity. As I said earlier, sensitivity is how accurate is our test in identifying disease in the people who truly have the disease. So amongst all those who are diagnosed as being diseased, how many of them were actually tested positive by the screening test? So that is known as sensitivity. In other words, it is nothing but the true positives from all those who were diseased. So as you can see here, this is a 2x2 table which shows you the outcome in terms of disease and non-disease status and the test results here. So if we can give the alphabets A, B, C, D to the individual cells in this 2 by 2 table. Our numerator is going to be all those who have been tested positive and are diseased. So it becomes A. These are our true positives because they have been tested positive on the screening test as well as been diagnosed as suffering from the disease by the diagnostic test. So that's our numerator A. And what's going to be our denominator? Our denominator is going to be a total of all those who are diseased, irrespective of the test result. And all those who are diseased are given by A plus C. So the calculation for sensitivity becomes true positives over total diseased, right? So this is the calculation for sensitivity. So the probability of the screening test in correctly identifying all those who are diseased. This is what is sensitivity. Okay. Now we move on to specificity. Now specificity focuses on correctly classifying the truly non-diseased individuals. So it is a probability that all those who are not diseased are actually classified as negative on your screening test. So this is the relevance of understanding specificity. So if you have to look at the formula for calculation of specificity, we are looking at this column, that is the non-diseased column, and what we look at is our numerator is all those who are tested negative and who do not suffer from the disease as D from the total of not disease, that is B plus D. So in other words, specificity looks at from those who really did not have the disease, how many actually were detected as negative by the screening test. So this is the explanation for sensitivity and specificity. Now, this is an example of a test which is used for screening for prostate cancer amongst males. So this is the test known as prostate specific antigen, and cutoff for positivity or a criterion for positive test is 4 nanogram per ml of the prostate specific antigen in the collected specimen. So if you look at all those males who had a value more than 4, they are put under the result of test positive, and those having a value of less than 4 under test negative. Now all these men, when they are subjected to a biopsy, so a biopsy is a diagnostic test to prove whether a person has prostate cancer or not. So what was done was, for all those males who were screened by PSA test, they were subjected to biopsy, and the results from the biopsy were interpreted as yes being those suffering from prostate cancer and no being those not suffering from prostate cancer. So for calculation of sensitivity of PSA test in detecting prostate cancer, we get the sensitivity as 818 divided by 930, because this is the number of all those who are tested positive and who are diseased, and this is the total number of disease. So our sensitivity is given by 818 over 930, that is 86%. Whereas the specificity of the test is given by those who are tested negative from all those who were not diseased. So it's 558 over 1690, which gives about 33%. Now the point to remember here is sensitivity and specificity are expressed as proportions or percentages. So the numerator divided by denominator multiplied by 100 will give you the results for sensitivity and specificity. Now, there's another concept which we need to look at. Before that, let's look at what we have done till now. So we have tried to look at performance of a screening test. In other words, the validity of a screening test by asking ourselves, amongst all the people who are actually having the disease or who are truly having the disease, what is the probability or the chance that the screening test will identify them as being diseased? So in other words, we are trying to look for the sensitivity. And amongst all those who do not have the disease, What's the probability that the test will categorize them as non-diseased? In other words, what's the specificity of the test? So points to remember: validity of a screening test is assessed by sensitivity and specificity. Now we have to look at another perspective. Now we have looked from point of view of screening for the test. Now another perspective would be, now if I have a test done on me and if it turns out to be positive, which in other words means that this test is abnormal and I may suffer from the disease. But as I said earlier, it is presumptive identification. So just by getting a positive result on a screening test does not put me into the category of being diseased. So if I have a positive test result, what is the chance that I really have a disease? That's one. And the other element of this would be, if I have a test done and it turns out to be negative, or at that point of time it is normal, should I remain happy? And should I say that, okay, good, I really don't have the disease? Or is there still a chance that I may suffer from a disease? So if I have a test done and it is negative, what's the probability that I really don't have the disease is another thing which we need to look at when we talk about screening tests. So when thinking about predictive value of a test, we are in other words looking at predicting, if I get a negative result today, whether I would be disease free always, or is there a chance that I may suffer from the disease. So when we look at predictive value of a test, we check, like, if this test was positive, our screening result was positive, how likely is it that he really has the disease. Now when I'm referring to he is the study on prostate specific antigen and prostate cancer. So if a male is tested positive having a PSA value more than 4 nanogram per ml, how likely is it, what's the chance that he really is having prostate cancer? And the other part would be, if this PSA test was negative or his value was less than 4 nanogram per ml, how likely is it, or how confident we can be in saying that he really does not have it? So in this case, we think about how worried this person should be if he has a positive result, and how reassured another person who has got a negative result should be. So this is what we consider as a positive predictive value and a negative predictive value. So a positive predictive value is the probability that subjects which have a positive screening test report truly have the disease. And negative predictive value is the probability that the subjects with a negative screening test actually or truly do not have the disease. So let's look at this example of prostate specific antigen and suffering from prostate cancer. So if I have to calculate the positive predictive value, what I'm trying to look at is, from amongst all those men who have got positive test results. So my denominator for this would be all those who are tested positive. So I look across, that is A plus B. That's 1115 in this given example. Of all these men who were tested positive, how many actually have the disease? So my formula for predictive value or positive predictive value is A over A plus B. So it is nothing but all those who are diseased from all those who are tested positive. So the positive predictive value for this particular example comes out to be 132 over 1115 multiplied by 100, given by 11.8%. Now, you may feel confused as to what's the difference between sensitivity, specificity, and these predictive values. So let's look at how to avoid this confusion. Imagine you are a patient and you have received results of your screening test, or maybe your doctor is telling you about the result. Okay. So if the test was positive, you would like to know whether you really have the disease. And if the test was negative, you would really like to know whether you do not have the disease. So this talks about the difference between sensitivity, specificity, and the predictive values. Now the next example would be for negative predictive value. As we said, amongst those men with negative test results, what's the probability that they do not have the disease. So this is your negative test result. The total would be C plus D. And from these, how many were not diseased are given by the cell D. So our formula for negative predictive value is D over C plus D. In this case, it is 99.9%. So the interpretation here is, from amongst all those who had a test negative, the probability of being disease free is 99.9%. Next, if we have to apply these calculations now for the example which we have seen before about the test result for PSA and biopsy proven prostate cancer, we have seen that the sensitivity and specificity results were 86 and 33% respectively. The positive predictive value for this test especially is 800 over 1932 multiplied by 100, giving it the positive predictive value of 41%, and a negative predictive value of 558 over 688 multiplied by 100, given as 81%. Now this data has been adopted from this particular study. You can find out this study, more about this study, by reading a BMC Family Practice journal article. Okay. Now, let's move on to a concept which is known as yield. Now, one factor which influences feasibility of a test which has to be used for as a program for populations is known as the yield. Now, yield is nothing but the number of cases detected of a disease by applying a screening test, and this can be estimated from what we have calculated earlier, known as the positive predictive value. So please remember one thing: sensitivity and specificity are characteristics of the test, and they will be influenced by only the test characteristics, and depending on what you have put as criteria for putting a person as positive and negative. But in contrast, the positive predictive value of a test, or what we call as the yield of a test, is highly dependent on prevalence of the disease in the population being tested. What is important to remember here is, higher the prevalence of the disease in the population being screened, higher is the positive predictive value and ultimately the yield of the test. So what is important here is, to increase the yield of a screening program, we need to target to test the groups of people who are at higher risk of developing a disease. Now, to illustrate the effect of prevalence on positive predictive value, I'm going to show you 3 different settings whereby you can check how prevalence affects the positive predictive value. Now, we need to be understanding here that we are talking about a disease, that is AIDS, caused by the virus HIV, and we know that AIDS develops only later, and we detect a person as either HIV positive or HIV negative, which means presence of detectable virus and absence of the detectable virus. Now, for your information, when we test serologically for the virus, this test, the screening test for HIV, is extremely sensitive, sensitivity going to 100%, and it is also extremely specific, 99.5%. But we need to understand here that the positive predictive value of this testing will be depending on the prevalence of preclinical disease in the population being tested. So now I'm going to demonstrate to you 3 scenarios here. If you look at this first scenario, the prevalence of HIV in this study population, wherein you can see the figures put down here, the prevalence of HIV in this total population of 100,000 is 10 over 100,000, which gives you a proportion of 0.01%. What it means is that even with 100% sensitivity and 95% specificity, the positive predictive value for this particular population would be only 10 over 520, which gives you a positive predictive value of 1.9%. So that low is the positive predictive value because the prevalence of the disease in this population is low. Now, if you apply this to prevalence of this Same table was for female blood donors. So if you see here, the positive predictive value is given by 1.9% for a test which is 100% sensitive and 99.5% specific, which is highly sensitive and highly specific. Now let's move on to how if the same screening program is conducted for males in a clinic for sexually transmitted diseases. So we go to a clinic which screens for STDs, and we try to look at prevalence of HIV amongst males in that clinic. And if we find that the prevalence of males is 4%, so we have to replace all these values like 4,000 here because it's 4 per 100, so 4,000 per 100,000, and then accordingly we can put the values in the individual cells. So with the same sensitivity and specificity, what happens is our positive predictive value now has increased to 89% because 4000 over 4480 gives us 89%. Now the third scenario, as you can see here, is it illustrates the yield if this screening program is applied to intravenous drug users in whom the prevalence of the disease is 20%. So with the same sensitivity and specificity here, the positive predictive value or the yield comes to around 98%. So the point to remember over here is the positive predictive value is greatly influenced by the prevalence of the disease in the population being screened. So we need to remember that sensitivity and specificity are characteristics of the test, and they will change depending on the criteria put for positive and negative test results. However, positive predictive value is influenced and changed depending on the prevalence of the disease. Higher the prevalence of the disease, higher is the positive predictive value. So if you expect a screening program to give a higher yield, you need to realize that that disease should have a higher prevalence of the disease, especially in the preclinical phase. That is the phase wherein the disease can be detected by the tests even before the symptoms and signs appear. Now finally, we are going to move on to, we have looked at cells A and D when we looked at the 2x2 table. But what about the cells B and C? What happens to people who are false positives and false negatives? So what do I mean by false positive and false negatives? If you look at these individuals, these are the ones who are not actually suffering from the disease but have been tested as positive by the screening test. Now, what happens to these people is they will feel worried because they are the ones who are tested positive. So they are unsure of whether they will suffer from the disease or not. So this adds to their worry. They will be subjected to a battery of diagnostic procedures, which adds to the cost. If the procedures are not risk-free, it can result in complications, and the test itself may be risky and can result in some health hazard. So those who are tested positive on a screen test but are not suffering from the disease have got an unnecessary trauma of suffering from the ill effects of the disease. If we look at the false negatives, that is the one who were tested negative but actually are suffering from the disease. Now these are the ones who will be reassured but in a wrong way that they do not suffer from the disease. Now the danger here is those who are screened negative on one occasion need not feel always reassured that they will never suffer from the disease ever in future. So the point to remember is when a person is screened for a particular disease, it may need a regular follow-up if the test results come out to be negative. Because for those who come out to be positive, generally people would go on for further tests and they would want to know what is the outcome of their test. However, those who are tested negative, they sometimes feel that there is no more necessity to go and get themselves screened or subjected to further tests, and this results in false reassurance, and if ever there is development of the disease, it will go undiagnosed or undetected for a long period of time, which can compromise the treatment outcome. So that's all about screening. Thank you very much. Keep watching and do subscribe.